My name is Corinne Hinlopen. I am a member of the Wemos team. Wemos is the lead organization of the AHEAD project. And Wemos is a civil society organization based in Amsterdam. And I myself, I'm the project lead of AHEAD. And for those who are joining an AHEAD webinar for the first time, AHEAD stands for Action for Health and Equity Addressing Medical Deserts. And the project aims to reduce health inequalities by addressing the challenge of medical deserts and medical desertification in Europe. Of course, you will hear much more about the project later on, because the aim of this webinar is basically to present the most salient findings, tools, recommendations from the project. And those of you who have joined webinars before, you will see some familiar concepts, of course, but we will neatly tie them together today and make clear also what you can do with it yourself and what we are going to do with it. This webinar is the last webinar of the AHEAD project because we are coming to a close at the end of this month. Yeah, you are saying like, oh, what a pity it is. It was a really interesting ride. But I'm glad that you are all here to celebrate, so to speak, our successes and our tools. We are holding this webinar in the European Public Health Week. And for those of you not familiar with the European Public Health Week, in this week, all kinds of events are being organized. And today's theme in the European Public Health Week is access to care. So you can understand why we are organizing this webinar today. Some house rules, you know them by now, I guess. If you have any questions or comments during the webinar, content related, please type them in the Q&A. Use the Q&A box for that. It will be monitored throughout the webinar, but basically we will get to the questions and the answers and the interaction with the panel and the presenter Aysel later on in this webinar. But if you want, you can already put them in the Q&A. The chat is mainly there, as I see it today, people presenting themselves, names, affiliations. If you want to, if you don't want to, this is also fine. Second, the webinar is being recorded. And of course, we will share the link to the recording shortly after the webinar. And please feel free to share widely then on Twitter, LinkedIn, Facebook, so that we can get even a wider audience for this webinar and its contents. Third, we will be using a Mentimeter today. So you could already find your phone, open your browser, go to the menti.com, just so that you are ready when they come your way, just as a heads up. So I said already, today's webinar is about tying all the knots together of the AHEAD's tools and findings and recommendations. And we have a fantastic lineup. Today's protagonists, you see them on the screen. You will be seeing them on the screen as well. We will first have Aysel Rahimli, who is the project coordinator of AHEAD, who will be giving a brief presentation, summarizing what we did and what we have produced. And then we have two panelists who will reflect on the presentation and also reflect on the AHEAD project. And those are ladies first, Dr. Mira Jovanovski Dašić, the director of the Southeastern Europe Health Network, and Dr. Branko Vujkovic, the manager of the Public Health Institute in Sabac, Serbia. And just to introduce the two panelists a little bit, because you may have seen Aysel before, so I'm taking her as a sort of a given. She's been a given to me for 2.5 years. So. But the panelists, Dr. Mira, you are the director of the Southeastern Europe Health Network. Yes, I'm saying it rightly. You have been a member of the AHEAD family for some time already because you are a member of our advisory board. But for those in the audience not familiar with your network, could you please explain in a few sentences what it is and what your role is there? And don't forget to unmute yourself before you do so.
Thank you very much, Corinne. Good morning to all of you. It is my honor and pleasure to take part at today's AHEAD webinar that is addressing medical deserts in Europe and a call for action. In order to familiarize our audience a little bit with the network, I will just say a few words about the Southeastern Europe Health Network, which is a multi-governmental, political and institutional organization for regional collaboration on health systems, and public health. The network was founded in 2001, so we are 23 years old. And the seat of the Southeastern Europe Health Network is in North Macedonia, in Skopje. I would like to say that this is a unique example of successful regional cooperation among 9 countries and health ministries of the Southeastern Europe. This network serves as a platform for trust building. And in the past 23 years, the network has many times brought these countries at the same table to pool resources among stakeholders and establish a shared vision by implementing joint regional projects on common health concerns. Cooperation at political and technical levels have resulted in long-term partnership between Southeastern Europe Health Network member states that I will mention in alphabetical order, which are Albania, Bosnia and Herzegovina, Bulgaria, Israel, Montenegro, Moldova, North Macedonia, Romania, and Serbia. The network has 2 also country partners, which are Croatia and Slovenia, and other 16 partners. Just not to forget that World Health Organization was one of the founding partners. So let's say this would be in short about the network.
Yeah, because I had a follow-on question like, why do you exist at all as a separate network? But you have actually really eloquently explained why it is necessary and what it also yields to the members. So, but we will be getting to that, of course, because you have a lot to say about that later on. Thank you, Dr. Mira. And Dr. Branko, you have been a member of the AHEAD family as well, but in the Serbian context. And I mean, you and I, we have only met 1 month ago in the European Parliament, but your involvement in the AHEAD goes way back. And I would like to ask you to say a few words about what your involvement has been in the Serbian context and what your role was.
Thank you, Corinne. At the very beginning of our webinar, I want to welcome all our colleagues around the world who are participating in this virtual public health space of ours. The Corona crisis brought some good things, such as accelerated digitalization and to better see and hear all stakeholders and all experts all around the world. And I want to thank Wemos and you to gather all of us in this great project. I am a general manager of the Public Health Institute Sabac, state-owned district public health institute in Mačva County in Serbia. We are one of the partners of the Media Education Center in the AHEAD project. Our part of work, I would like to say like that, in this project was to bring all of the stakeholders from local level and district level, NGOs, citizens, healthcare workforce, healthcare managers, and the local municipality authorities together, and to organize all context building sessions, and to create some conclusions for the national authorities. And that was our part of work. And also together we already are working along about this context, but AHEAD project and our tools which we together created give us some new thinking about how we best can reflect all problems with the deficit of healthcare workforce and different needs of people in the different municipalities.
Yeah, fantastic. It's really nice to have you here too, because this consensus building has been a cornerstone, of course, of the AHEAD project. And we will definitely come back to that and what it yielded you also in the Serbian context later on in the webinar. So I very welcome Dr. Mira, Dr. Branko. I'm really delighted that you have found the time to make yourselves available for this, because you have important reflections to share. We will move on for now, but before we dive into Aysel's presentation and the panel reflections, we have a bit of interaction. As I have already announced, we will be using the Mentimeter. So I would like to ask you to go to the Mentimeter, and Pearl will be sharing, yes, in the chat, the number of our of the website, or whatever you call it, the tool that we are going to use. And Pearl, of course, sorry, I did not mention her. She is here as well. She is our communications advisor and behind the scenes. And as you said yourself, Pearl, you are omnipresent, taking care of all the background technical stuff. Yes, what country are you joining us from? Can you please share that with us? And should you be somewhere in the Caribbean enjoying a holiday and logging on early just to follow this webinar, but normally work in Paris, then I would invite you to put in Paris and not the Caribbean. But anyway, I see already some words coming in. Yes. Belgium, Netherlands, Kenya, interesting. Moldova, Macedonia, we have more people. Let's get there. Netherlands again. Italy, nice. Welcome all. And the bigger the letter type, the more people from that country, right? So that would be Scotland, nice. Would be nice to hear about that as well. Yes, are there still coming in? I don't see any movements anymore. Thank you so much. And the last one I think I see, oh, there's still some. Greece, nice. Nice. Good to see all of you here. Belgium, big representation, nice. Netherlands, yes, way to go. I saw a few people on the registration list that I think I know from my work here in the consensus building. Nice. Serbia's there, yeah, interesting. Let's move to the next slide though, because we have 3 questions before we move on. In what capacity are you joining? What is your role in your daily life or in the AHEAD project? How have you been involved? What is your interest? Are you a researcher, a policymaker, a health professional, a health manager, a facility manager, politician, patient representative, whatever, policy researcher, a university researcher, public health consultant, university, national partner, fantastic, academia, researcher. Whoa, this is coming in nicely. Data statistics, nice, yeah, lots of things that we have been doing with data and statistics. Board member of Health Systems Global. Interesting, welcome. Activist, yes. Program manager, policy researcher, national partner again, policy officer, health NGO, nice. NGO founder, nice. That is really interesting, a bunch of people and a nice mix as well. Being a health advocate myself, and Wemos, of course, in civil society organization, I'm very happy with the activist participation. PhD researcher, yes. Consultant researcher, yes. Thank you so much. It's still movement. Was there something new there? Physician, so we have a doctor there too. PME, project monitoring evaluation, nice. Last question, let's move on. in your opinion, and when it comes to medical deserts and medical desertification, and sort of reflecting from your position, what will happen in the next 5 years when it comes to medical deserts and medical desertification in your country? There will be more, there will be less, it will be more or less the same. Oh, wow, look at this. There will be more, there will be more. Okay, so that's an overwhelming majority saying there will be more. It will be nice to, at some point, see some reflections on that in the Q&A, for example, because I think that there will be ample time to discuss a couple of the tools and outputs of AHEAD to make sure that you can use them in your work to address the medical desertification in your country. So in that sense, we have hit the jackpot with this audience. Thank you so much for inputting your answers. So that was Dementi.com, and we will be moving to the next part of this webinar, and that is the presentation by our project coordinator, Aysel. And I would say, Aysel, take it away.
Yes. Good morning, everybody. Thank you very much, Corinne. And indeed, it is my pleasure to present to you, give an overview of what we have been up to in 2+ years, and show you some of the tools and some of the call to action as well, which hopefully we can all join on and also use to address and hopefully have less medical deserts moving forward. For that, I have a presentation to share with you all, and I would like Pearl to please pull it up if that's okay. Yes. Perfect. In a PowerPoint mode. Thank you so much. Indeed. Yes, so let me start with, first of all, give you a brief overview of what we knew before the project even started. That is that the COVID-19 pandemic has highlighted and exacerbated the inequalities and also the differences among the EU member states' health systems even further. We know what the healthcare workers were facing, the challenges that you can see on the screen. Of course, there are shortages, maldistribution, undervalued skills, mismatches, and aging workforce and the population. And I think we know what this has caused. I think it's also important to highlight particularly the maldistribution in the regions when it comes to the density of the physicians in the European member states is more than 5-fold according to the European State of Healthcare Panel Report from 2021. That really highlighted also the need to rethink the health workforce strategies across the Union. In that report, there was also, it was highlighted that there was a challenge in the recruitment of the health personnel when it comes to particularly the physicians to the rural areas. And of course, there's evidence that there has been some strategies and the policies that have been implemented, but to varying degrees and with varying success rates. So, with the AHEAD results and the tools, we worked towards the solutions from these issues and also from specifically the medical deserts perspective. On the next slide, I want to take you back to spring 2020 when the European Commission launched a call for proposals under the EU Health Programme with the aim to support the reforms in the health workforce field. This call specifically asked for the initiatives to have the objective of, to support the member states in the design and the implementation of the policies, and to do that through the development of the supporting tools and guidelines, and scaling up good practices, creating a platform for policy dialogue, and to advance on these challenging issues. And to kick it off, the European Commission has shared a short definition on the medical deserts, also as a guiding principle that you can see here on the screen. And some words to highlight in this case is, medical deserts are thought to be isolated areas, those with low concentration of services, falling number of practitioners, etc. On the next slide, our first challenge was to come up in AHEAD with something a bit more concrete when it comes to the definition, something a bit more tangible. It was, of course, we also realized it was quite challenging because our countries of the AHEAD project are also quite diverse in their context and also the overall EU context itself as well. although that's a challenge, it's also the beauty of it. And we identified that the context and the contextual elements are really quite paramount to this work. On the screen, you can see a short definition that we have come up with in a project, which reads as that a medical desert is the endpoint of a complex process called medical desertification that implies continuous and increasing inability of a given population to access health services in a timely and contextually relevant manner. And on the HEAD website, and you will have a link for that in the chat very soon, you will find a more elaborate and a detailed explanation on what some of these keywords really mean, and also some examples of the indicators and factors that can be associated with them. And of course, this definition was validated through our several research activities and in other contexts as well. And on the next slide, then, yes, I want to highlight some of the challenge or the aims of the project, which was first and foremost to firstly generate evidence and build stakeholder knowledge on medical deserts and their related policies in our project countries. Secondly, to develop and build a consensus on context-specific feasible policy measures to support the policymakers. And thirdly, to ensure joint reflection on the effective, feasible, acceptable policy solutions, also among the national and the European key stakeholders and other relevant decision makers. On the next slide, I want to summarize some of the guiding principles of the project that we had. Firstly, I said already, context is everything, and we really need to tailor it all of our interventions and all of our conclusions. It's especially important for quantitative and qualitative data collection, as we found those were available to varying levels of details and often including also different types of indicators across the countries. This, of course, affected the methodologies and the conclusions that can be made in the countries as well. Secondly, it's also important to engage those that were affected. So this means that those in isolated communities, the health professionals, local policymakers, and everybody who knows their lived realities. Finding consensus and engaging on agreeable and feasible policy measures that can be implemented in an efficient and effective and sustainable manner was also really key. And lastly, we based all of our interventions with the aim to produce practical tools for the policymakers and developed what we call our unique selling points, which is the interactive maps of medical deserts and the consensus building methodology that was already mentioned, and I will dive into that very shortly as well. But before doing that, on the next slide, I want to highlight some of the root causes that we have came up with, and to highlight that. Well, firstly, there is an increased need to use the healthcare system. So there is an increased demand. We know the things I already mentioned. There's aging population, there's higher administrative burden, ask for GPs, lack of preventative strategies, etc. The things we've touched upon already. There's also decreased supply. We know that GPs are retiring, also highlighted by WHO Time to Act report. The 40% of the healthcare workers will be retiring in the next 10 years. There's limited number of young doctors who want to be GPs, to name some of the issues associated with the supply side, and also to highlight that the general context as well is a determining factor when it comes to the medical deserts. Have to consider things, the challenges with infrastructure, facilities, and also other things such as maintenance of the roads, or seasonal challenges that might come up in some countries that we have also seen in our research. And on the next slide, some general conclusions as well to add on to that from the diverse country context. Firstly, to highlight that the terminology that we use, the term medical desert, in many cases was not a familiar term, so to speak, but there was always a good understanding with our stakeholders when it comes to what the concept is and the problems around it. We also learned that the GPs and family doctor densities are the most important factor in this, and also when it comes to the access and to the facility where they are based, which is measured by time and distance. Of course, this is, I said already, a complex societal problem that requires complex decision-making processes. And there is also, we learned that challenges or no clear ownership of the problem or the solutions, and which was also how our activities will hope to contribute to that as well. On the next slide, there is, I want to highlight, well, in addition to the definition that I already showed you already, which was one of our key outputs for the project, we also came up with a methodology for calculating a medical desertification index, which is a step-by-step approach that can consider both the demand and the supply side in a given locality to compute it into an index that indicates the stage of medical desertification and the areas that can be identified as high risk or becoming one, or in comparison to the national and the local norms. You can see a formula here, and which might look rather complicated, but we broke it down into a 4-step approach and have the specific instructions of how to apply that in the steps are available on the HEAD website with a link that will be shared in the chat as well. So I will not dwell too much on this right now, but I want to highlight to you our unique selling point of a diagnostic tool, which is on the next slide. This is a publicly available tool. It's on our website as well, and it can be used by anyone. Of course, it focuses on our project countries at the moment that you can see on the screen. And it compiles sort of a set of features that together can identify and illustrate where the medical deserts visually can be found, and if implemented in the same way, following the tools and methodologies that will link them. In a nutshell, there is 4 sort of elements to it. Firstly, it is the illustrative story of a lived reality of what happens on the ground. Secondly, it includes a report on the medical deserts per project country that you can see here. We also defined a selection of indicators for the wider context setting. So what does it mean in a country on healthcare access? And you will have several maps that are based on the contextualized also set of indicators that highlight the high-risk areas where you can investigate the medical deserts. And we also did a webinar on the details of the tool as well, and there is further details, and we will of course link it for quick access for you too. But for now, on the next slide, there is consensus building, which was already mentioned, and which is what we use to find the solutions in those areas and to find consensus among those who live there and also the national stakeholders. We piloted this methodology in several case study areas and also evaluated the process as well. To highlight this methodology was used to, well, firstly, obtain a general agreement among the relevant stakeholders on the most appropriate policy options. This does not mean that there has to be an agreement in every single aspect, but to have a general agreement that there's an option is the right one and something everybody can support. In our project, we focus on the options that focus on a wide range of locally developed innovative solutions. And what we do know is that the process does lead to better decision-making, but involving different stakeholders and ensuring they're contextually tailored and sustainable. On the next slide, I want to dive into the phases of this approach that we implemented. Firstly, this starts with local level homogeneous sessions, whereby there's 2 to 3 separate groups of what we call homogeneous participants. So those such as community members, local policymakers, healthcare workers, and they come together to focus on the validation of identified problems and then the brainstorm on some of the preliminary solutions as well. Then it goes to the next phase, which is held with the local multi-stakeholders. And this group consists of also representatives from the previous subgroups. And the focus here is on the integration, joint problem solving, and building consensus on these policy options, which then are taken to the last phase, which is the national level sessions. That includes representatives from all the other sessions and also the political decision makers. And here the focus is on codifying these policy options and that are developed in the previous phases, and then create an output of a handout of feasible menu of the policy options that are appropriate and contextually relevant and sustainable. Again, we had another webinar on this already, and we have some other developed products that you can read about this in detail from the links in the chat. But now on the next slide, I want to dive a little bit more into the policy solutions that came out of these sessions. And they can be summarized into, well, technical, so developing strategies, guidelines, improving data availability, but also political solutions, so sharing political commitment, writing them down in the policy programs, etc. What we want to highlight here is that we discovered that we can categorize them a bit further into, well, actions, firstly, that fall within the Ministry of Health directly, and those to be implemented on a national level. Then there was actions that require close collaboration with a diverse range of actors with different perspectives and mandates, and also other sectors as well. And thirdly, it is the actions that focus on empowering those from the local communities, especially those from areas that could be considered medical deserts either now or in the future. On the next slide, well, yeah, the cross-cutting theme that came out was governance, which can be implemented also, can be interpreted also as ensuring that there's a technical and a physical capacity to, well, firstly, assess the localities that could be medical deserts, and then secondly, take action to mitigate them in a contextually relevant manner, and also escalate them to the national stakeholders when appropriate. To create this capacity, member states have the responsibility to allocate firstly appropriate funding. And of course, this can only be done if there's a political will that is beyond the political cycle of the politicians. This funding should be made available in light of ongoing regional developments. And an important advantage of using specifically EU funding to implement these solutions, that it creates a strong incentive to ensure accountability and the sustainability of these solutions as well. On the next slide, well, these themes were discovered, it was also for us an opportunity to use these findings to call those in power to go ahead and also now tackle medical deserts. So next slide is about the call to action that has already been mentioned earlier. It's a 3-page document. You can also find it on the website, but this call to action sort of targets specific audiences or target groups that you can see here on the screen. There's, of course, the European institutions, the member states, the educational institutions, the health professionals, and of course, the citizens. And I will dive into some of these asks summarized into some key points to give you a brief summary of what they are. And the first one is on the next slide, the EU institutions that we're targeting. Well, firstly, it's important that to elevate the political agenda and make that medical deserts a top priority throughout the next Commission's mandate and also the beyond. And as I said, political willingness is really quite key to this. Secondly, it is to use and apply the available data and tools and to fill the gaps in the data that is available or is meant to be collected. And funding is key to mitigate this societal issue, and funding instruments need to be more accessible and also widely shared. And it's important to map and report how these resources are being used directly to address medical deserts. That also ensures accountability. On the next slide, we have the member states, our national level actors, and it is our ask to first improve the quality and the systemic data collection and its analysis, and to use the available tools that we developed also in a head that I already mentioned. Creating a dedicated task force, so the governance with a capacity to both the physical and the technical, to develop and implement the national strategy on how to identify and address medical deserts is a second ask. And it is important to recognize that citizen participation as a founding principle of the national health system, and to apply then the multi-stakeholder dialogue methodology such as consensus building methodology that I explained earlier. And it is to then increase the context sensitivity, applicability, feasibility of the policy solutions as well. And of course, increase investments in health, education, economy, and connectivity by involving this diverse range of actors and the sectors. The next slide is about the educational institutes, those that are responsible for the health workers training. First, the ask is to, well, there is a need to continuously adapt education of the healthcare professionals to the population needs and also the health service requirements, especially when it comes to the most vulnerable, by paying specific attention to those that live in rural and remote areas. It's important to implement and improve task shifting practices and update the digital skills across all cadres and the healthcare personnel, and ensure that there is a continuous education and a professional development with a particular attention to those that live, again, in the rural and remote areas. And on the next slide, we have, last but not least, a tool and important that the healthcare workers, their associations, the citizens, and their advocacy groups. And the ask is that those are actively participating in the co-creation of policy solutions, so being part of the method, for example, the consensus building methodology, to advocate for the right for health for all, and also to create further awareness on the needs of the most vulnerable, including the populations in the medical deserts. As I said, you can find a full list of these actions on the website and read further into that, and that is still open for endorsement and feedback if you have any. And next, at my last slide, yeah, just to summarize, I hope it's a clear overview of our activities, our outputs in the last 2 years, and what we hope to see in the future happen on this topic. And thank you very much for your attention, and I'm happy to take any questions.
Yes, thank you so much, Aysel, for this very comprehensive overview. We've done a lot of work indeed, and this was a nice summing up, actually. Before we move to some of the questions of the audience, because I already see some movement there, of course, we have the panelists. Again, thank you very much for joining us. And I know you have a lot to share. Aysel pointed out neatly that we have been focusing on sort of the technical managerial side of health worker shortages and medical deserts, but also on the political side. So creating the political will, elevating the topic on the political agenda. And first about the sort of the more technical side and also the implementation, the use of the tools that we have developed, I would like to go to Dr. Branko first, because you were very hands-on involved in the consensus building sessions, in the organization of them, in the participation of them. And we would really like to hear a little bit from you how this worked out in Serbia, or in your area, in your medical desert area, Sabac. And what this yielded in terms of policy options, and the will also to use, to implement the policy options, and the political will that came with it. Please, Dr. Branko, if you can unmute yourself and share your experiences.
Thank you, Corinne, again. And first of all, I want to thank Aysel for a great presentation. And like we saw in presentation of funding, political will, region development, and accountability, accessibility are the core pillars for implementation of strategies of and further development of this project and all projects which we are going to do in the future in fighting the desertification of our county. After a set of meetings with different group of stakeholders, and like I said already, we organized sessions with local authorities, with the NGOs and the civil societies, and also patient groups, and also managers of primary health care centers, and also GPs which are working with the patients directly, and together we found a lot of different thinkings in local groups, but in multi-stakeholder groups we found some key findings, and I think it's a great knowledge for policymakers to create some national, regional, and local policy actions to tackle the medical deserts. Well, the desertification in Serbia is a new term, but it's an ongoing process for more than two decades, and we must tackle it, and we must tackle it now if you want to make accessible healthcare. We identified some different criteria for medical deserts in Serbia, and I must say, when we talk to patients, a lot of them are talking not only about accessibility of directly accessibility of healthcare workforce and the number of working hours, waiting time on healthcare research, but also public transport from their place to, because we in our country have some different rural areas which okay, they maybe have infrastructure, but they don't have public transportation available. And when we talk with the local municipality authorities, we came to some conclusions which are good to tackle the not accessibility of healthcare in that areas. Probably the key, I would like to say more about that, but probably the key policy option we have found is that health services and the health workforce standards should be set at the local level because of all contextual specificity. And I think maybe that is the key finding of our Public Health Institute, and which Media Education Center put it on the agenda for the national authorities, because organization of the primary health services in Serbia are centralized and not decentralized, and put it in the local authorities. So the local authorities can do a lot in public transportation and reorganization of supportive services for healthcare workforce, but not to create such main things like to pay some money for workforce, or to make mobile teams, or to make mobile pharmacists, and we can local municipalities can invest in local infrastructure for digitalization, but they cannot do anything more about this. And maybe because till 2017 we have decentralized primary healthcare system, but it not was totally decentralized, because paying was from the health care insurance fund, state's healthcare insurance fund, and only when you're paying, and that is what local municipalities was saying to us. Okay, but we cannot put the agenda on the priorities of primary health care and to tackle in full capacity with medical deserts if we don't have our management, and we cannot invest in primary health care. Okay, we could buy some vehicles and we could buy some things for the primary health care, but we could not create local politics, local public health politics, and that is one of the main conclusions of our stakeholders. Also, the digitalization is a priority. We saw it in all medical deserts in our project, that digitalization is one of the core pillar of fighting medical deserts, because and in developed countries, low and middle income countries, we have less workforce, but aging population, we saw it in a call for action also in our draft version, that we have higher demands, and the needs of the patients are higher because of aging population, but supply is more and more going to be worse than in this point. And also we saw in our Mentimeter that the old colleagues are watching us. They are thinking that medical deserts will become a more and more bigger problem. The reasons are all of this, what we're talking about, but we must implement, and we must invite, like we said, different actors to work closely together, and we must not act, and we are speaking now, but we are maybe already late for action, but we must act now to prevent more desertification of healthcare services around Europe and around the world.
Yeah, fantastic. Yeah, that is a really interesting intervention, Dr. Branko. And I hear a number of different things. You were saying basically one of our mottos, which is context is everything. There is no one size fits all. So you need to come up with context-specific solutions also. What I also heard you say is you need the different actors to do their part, to play their part in the solution to the problem of medical desertification. The transportation one, that's not done by the medical sector. Providing the digital infrastructure or the infrastructure for digital innovations, that's not done by the health sector. You need different actors to come together to all play their part. And I was wondering also, Dr. Branko, because you were so closely involved in that consensus building, in these participatory policy making, did you find it difficult to get the different people around the table and speak openly about, the problems and the possible solutions?
Consensus building methodology is definitely a great tool to get info from different stakeholders, and we didn't have really didn't have any problems, because and we get great decision-making sessions because we are a public health institute, regional public health, and we have great connections with all the stakeholders. In all our work, we have contacts with patient groups, with NGOs, all kinds of NGOs, in social care or healthcare, and also in social care institutions, primary healthcare institutions, and local authorities. And maybe one of good things of Corona crisis is that we connected more tightly together in pandemics. We have a lot of things to work together, and I think that consensus building methodology will be our guiding and most valuable tool in decision making, in all decision making, in regional healthcare policy.
Fantastic. You are a great advocate for the tools that we have developed already. So it helps to be already well networked and well connected in the region where you want to work. I hear you say that, that's your institute basically, and to have that basic level of trust so that people feel confident and safe in this participatory policy making. Yeah, those are important points of departure. Moving to Dr. Mira. And because you were saying, Mira, that your network is the more political institutional network of national institutions, public authorities. And you were so kind to invite us to one of your meetings last March, where our project partner Sergiu from Moldova participated and explained a lot about AHEAD. Can you reflect a little bit on how the project and its tools and its outputs were received in that in that network and how it has inspired the members to do something also on medical desertification, please.
Thank you, Corinne. But before going to that part, I would like to congratulate Aysel for the excellent and comprehensive presentation, and also to Dr. Vujkovic for giving additional explanations that make everything clearer. So yes, I have to say that the Secretariat from the Southeastern Europe Health Network from the very beginning found the HEAD project a very important one because, as you know, the mission, as I have mentioned, is to improve the well-being and the quality of health for the populations of our network. It is true, our network has its political part and it has its technical part, that it's working through our regional health development centers. And the Regional Health Development Center on Human Resources is hosted by Moldova, and Sergio Odgon is part of it. So what it was important that not only a couple of years at the plenary meeting, we had a presentation on the HEAD project, but also recently in March in Tirana, we presented the results of the HEAD project. Of course, Sergio was present in person, but he was backed up by Professor Milena Santrec-Milicevic, and of course by you, Corinne. And I have to say that it was really well received, the presentation on Moldova and generally on the other selected countries that you mapped. And what the conclusion I can say was from the representatives is to continue with this project and of course include all our member states. It is true that this is a challenge because within the network we have 5 of the Western Balkans that are now candidates to the European Union, and of course they are working on many other issues as well when we are talking about health. And we know also that the health systems in the past couple of years were really disrupted by the COVID situation, and they are now trying to catch up, especially when we are talking about non-communicable diseases, which really were left out, and everything was shifted to COVID-19 and the communicable diseases. But I have to say that the results from the meeting really showed that it would be necessary to map the situation in the member states when we are talking about desertification, because following to that, other plans and strategies can be made, because it is also true that from this area, from this region, a lot of the medical professionals migrate, they leave the country, and additionally are making desertification and leaving to countries of the European Union. So, of course, this is not, when you map the situation is in a country, it's not something that is fixed. It is something that is continually moving and changing, and it is necessary to follow that. But the interest is there, and hopefully we will find a way to solve and find a solution to map the desertification also in the countries of the member states of the Southeastern Europe network. So the support is there, but of course we need also to work more to disseminate this information. Only with that we could influence the political part of our network and maybe find a way funding to continue this project. And of course, we are also looking at the European Union that is supporting the Western Balkans to improve their health systems. And maybe there will be a possibility to continue this project and to have a bigger view of the situation also in the Southeastern Europe region.
Yeah, absolutely. That is music to our ears, Dr. Mira, because of course we would love to continue the activities. We see so much potential, not just for the tools that we have produced, but also to continue the momentum that has been created over the last couple of years. And it's really nice to hear that from sort of the technical side, using the tools, seeing the maps, using the interactive maps, there is also the political, well, or the policy momentum, the policy interest from your members to actually start working on it. So yeah, great. I know that you're also a great advocate of our work. So please spread the word indeed. Do you think that the methodology, as we have been discussing, the consensus building methodology, is something that could also be implemented in the member states in your network? Or is that something that resonates with the way you work there? Well, not you, but the member states.
Well, I could say that there is the possibility, and of course, when we are talking about the technical parts, as I have mentioned, we rely on our regional health development centers. So I am looking at Sergio. And Dr. Nikolai Yalamsky to have support from their side, and to continue the process and to use the tools. And hopefully in some further time, we will be able to have some results also from the other member states, because in your project, there are 3 of our member states, which are Moldova, Romania, and Serbia. Yep. So it would be good to enlarge this project to the other member states, and of course with the support of the Regional Health Development Center from Moldova. But I would like also to say that in the meantime, we could really rely on the call to action that actually Aysel presented on her slide, which is she included the European institutions, the member states, the education institutions, the health professionals, and of course the citizens, which of course is very important in the meantime for these people that are having these issues with the access to the health care services. Is important that the health literacy is increased there. It is also important to have better promotion, prevention of the disease. And of course, personal health care is also important, and including the digitalization that was mentioned by Dr. Vujkovic. These should be the key things that can be improved in the next period until there is the full political will and of course the budget for all of that.
Yeah, that resonates very much with many of the policy options that were developed in the countries, given that in most of the countries, the shortages of health personnel are only increasing. You need to invest more in prevention, health promotion, health literacy, digitalization, so also digital health literacy. So it's not just the health workforce policies that you need, it's much more than that, actually. Let's move into the question and answer session of this webinar. I haven't been monitoring the chat or the Q&A, I should say. I saw a couple of things come by in the chat, but I haven't followed closely. I did see Sergio, of course, with his question, like, do we need an AHEAD 2.0? We would really love that. We will be very much prepared and willing to participate in that. We haven't identified any concrete options yet, but who knows? If any of you in the audience know of an opportunity, let us know. But Q&A. Aysel, I think you were the one who was going to monitor the Q&A. I think there was also a question in the chat that you said you might want to take yourself. Is that correct?
Yes, that's right. There was a few questions in the Q&A. I think a couple of them have been answered, but for now, there's a question I think I can say something about by Nora Lorenzo, who is from the European Cancer Organization, if I understood that. And the question is, Nora is wondering, European level tools, they have defining a number of healthcare professionals, service providers, focusing majority on medical doctors, nurses, and pharmacists. Of course, GPs are also key, but there are many other actors in the health workforce that might be lacking even more in the medical deserts. So your question is whether AHEAD is conducting any work or developing tools to further quantify other healthcare professional categories. If I can take that one, I think it's a very important point actually to highlight this. Well, of course, in AHEAD, we're focusing sort of on the basic needs of the healthcare access. So the very, without specialization, such as perhaps the cancer care. And we specifically focused on the GPs because they're the gatekeepers to the healthcare system. And we also found, let's say, in some context, pharmacists have a really important role in some of our countries, maybe more than others. So it was an important element as to why to sort of not just focus on GPs. We also looked at of course, pharmacists, nurses, etc. And of course, other let's say professionals are very much key to the healthcare delivery, and that's why we also advocate to have better task shifting and sort of including other practices where work can be shared. But the data also with identifying even the other professionals becomes to what we mentioned about data availability. Do we have the data about who are the other cadres in those localities, in, let's say, isolated communities, to, let's say, to have it granular enough, so to speak. But it does not, so in our AHEAD project, we're not looking, let's say, on the cancer necessarily or other sort of specialized services, but more of a general access. But of course, as I mentioned, our tools are quite adaptable and they can be contextualized. So in that essence, I think if you have a specific angle that you want to look into specific professionals, it is possible to adapt things or even the maps or identify indicators that can be used for other services, service providers, so to speak. So I hope that answers that question.
It was an excellent question and an excellent answer. Yes, thank you. Any other questions in the question and answer?
There is a question by Clementine Richard, but Dr. Branko has already wrote something.
There is a question by Goran Zangana from Health Systems Global. It appears that addressing medical deserts in Europe can sometimes exacerbate such shortages in LMICs by recruiting health and care workers from the latter. Has this issue been explored and how do you suggest to address it? That is a very excellent question. Dr. Mira actually alluded to that already, the outmigration of health and care workers creating actually a sort of medical deserts. as for AHEAD, we have touched upon it superficially. Of course, you may be, some of you and also in the audience may be aware that Wemos is also leading another project on that, which is called Pillars of Health, which is much more focusing on this sort of European-wide and also global availability of health workers, including migration and mobility. But it has not really been addressed in the AHEAD project as such. I'm not sure if perhaps Dr. Branko or Dr. Mira would like to add to that, to what extent, well, Dr. Mira, you already mentioned it a little bit. Dr. Branko, I don't know to what extent this has been a topic of concern in your area, in your work. If you can unmute.
Okay. Yes. Thank you for the question. Definitely. The methodology and the measuring of desertification in EU countries and other more developed countries are problem for more desertification in our country, and also in lower and middle income countries than Serbia, because we definitely have flowing of healthcare workforce from more richer from less richer countries in EU to United States, to Scandinavia, and UK and Canada also, but also in EU countries. I was talking in Portugal last year with some colleagues, and they told they had a lot of shortages in healthcare workforce, and also in Belgium. They are going to there maybe one of parameters, key parameters, is wages in richer countries, and but okay, we must, and I told here in chat to Clementine from France, context is everything. We must analyze all things which are important for every country, but we must not say that this tool we develop together, desertification tool, but we must implement it in all of our countries, and we must together with patients, NGOs at first, because they know what their needs are, and they best know what their needs are, and when they say to local policy authorities and regional and national policy authorities, when they say we must have this and this, we must see that is that the digitalization, is that transportation infrastructure, and all of kinds of intersectoral activities, which what we are going to do. If we talk about that okay, Corinne developed that in Belgium or in Netherlands or in UK or in Macedonia, and they will, if they develop that tools, they will get our healthcare workforce. No, it's not. It's not the question about that. It's a question about context, and we must take actions, and call for action is good because of that, because we call all stakeholders in all of our countries to act together and to analyze the context of our countries, and to make key policy changes.
Yeah, thank you so much. That's an excellent again advocacy message. Act together and act now, and that's also why we actually develop the call to action, is that we want to elevate also the topic to supranational level. It's not just the member states concern, but it's a European concern, and not just the European Union, but the European region. That's why I'm so excited about what's happening in the Southeastern Europe Health Network. And then actually onwards, it's also a global issue, the availability of health workers. And it is our aim also with that call to action then to make politicians, policymakers at the supranational level aware that there should be some concerted action that is needed to solve the problems of availability of health workers. Yeah, thank you so much. I have seen that it's well past 11. So I think it's time to start wrapping up the webinar, but we have one Mentimeter question for you. And that is putting all of you in the audience a little bit on the spot. And Pearl, I hope that you will be able to pull up the last Mentimeter question. Yes, there is the Mentimeter question. The last question, which is about the AHEAD outputs. You have seen all our outputs, tools, methodologies, and we would really like to hear from you. Which of the AHEAD outputs do you intend to start using in your work? And don't be shy. And we really understand that you will need to dive into how it works and you will need time, sure enough, but what appeals most to you and what do you really intend to start using? Answers are coming in. That is nice. The consensus building, the tool, the diagnostic tool, the research tools, research briefs, the medical desert index calculation. Nice. Nice. So the definition is not too much of a appealing USP. Okay, the policy briefs. Yeah, there's interesting knowledge dissemination in there. Call to action, I would really, well, we'll say a few words about that one too. But this is not, keep it coming. I know there are more participants than the ones who have reacted to the question now. So it's going to be a tie, I think, between the consensus building methodology on the one hand and followed closely by the research tools, research briefs, and medical desert index calculation. That is nice to see. That is really nice to see because indeed these are, the consensus building methodology is what we found really innovative and challenging, but very rewarding as well. So I would really indeed encourage you to take a better look at how the methodology works. Oh, there's still answers coming in, nice. To see how the methodology works, to familiarize yourselves with how you could implement it. We have the explainer slideshow, we have a webinar also on the topic specifically of consensus building. As we have more explanation and a separate webinar on the medical deserts diagnostic tool, including the index calculation. So please have a better look. If you have any questions when you start using them, please do not hesitate to get in touch with us. I see one vote for the call to action. Thank you very much. That gives me the opportunity. Thank you, Pearl. I think we can stop sharing. The call to action. The call to action is on our website. You can still provide some input if you are missing some elements in the call to action or want to give some more fine-tuning or details. And of course, there's a room for endorsement. And we would really encourage you to endorse the call to action so that we can bring it forward also further into the European institutions. And for your information, I think you have all seen it, we have had a very productive and engaging roundtable discussion in European Parliament almost exactly 1 month ago, where many of us were present from the team, and also Dr. Branko has been able to join us there. And this has really kick-started the multi-sectoral discussion at the EU level. And this was very encouraging to see. There are a couple of follow-on activities under consideration now, like specific webinars. So keep following us. The AHEAD project officially finishes by the end of this month, but all of the project partners are actually somehow already now so much involved in country level specific activities that there will be really some follow-on activities. Modules in continuous professional education, in the health education institutions, the civil society participation and the participatory policy making. I know in Italy is very strong there. So we are not dead, we are still here. So if there's anything you want to share with us or point us to, or if you want to know something from us, visit the website, get in touch with us. We will be happy to discuss with you to bring this important topic forward, elevate it higher on the political agenda, help you with the tools or whatever else. I would like to give a final opportunity to our esteemed panelists to say a few closing remarks, if you want. Dr. Mira, perhaps you would like to state something. Yes.
Just shortly, I would like to thank you for this excellent webinar. And of course, we will keep high on the agenda the AHEAD project, and we will try to disseminate as much as possible to the member states of the Southeastern Europe Health Network.
Fantastic.
Thank you.
Yeah, and if at some point we would like to set your example in the network in the European Union, we may want to contact you again and to showcase what you have been doing in your network on this topic as an example to the other European countries. Yeah, that would be great. Dr. Branko, final remarks.
At the end of our project and of our webinar, I would like to thank you, Corinne, and to your organization, Wemos, great advocacy organization of EU and non-EU countries of all group of patients. And I would like to thank Media Education Center, which was a project leader in our country, and also to our Spiritus Movens Professor Milena Šantrić-Miličević, and all we said in our call for action: act now, act together. Together we are stronger, and we must think about all vulnerable groups at the first place. And I hope that this project will be only the first step in moving forward in implementation and evaluation of other projects which will be developed under these desertification tools.
Fantastic. I couldn't have closed this webinar better. Thank you so much for your closing remarks. I don't think there's anything else left to say. I thank you so much, Dr. Mira and Dr. Branko, for making yourselves available and share your valuable insights and experiences. Thank you to Aysel, of course, not only for this excellent presentation, but for your project coordination as well in the last 2 years. Job well done, really. Nothing else to say then. Thank all the participants also for your active attendance, your questions. We are here if you want to reach out to us. Thanks to Pearl for the technical backup, and I wish all of you a great day, and let's be in touch in the near future. Thank you so much. Bye-bye.
Thank you. Take care.